And in the theme of subgroup analysis, just a couple of comments I want to make. One is, you know, again, the never smoker group in this patient population benefited. And then the only group that really didn't benefit was the EGFR mutant patients. And this came up in a discussion, you know, what do we do with those patients? And I know it was a small number. I think it was a total of 20 to 30 patients.
And the confidence intervals
it was quite wide.
unity, but it was still in the right direction.
Yeah. So this has come up. What do we do with an EGFR mutant positive patient who's stage 3? I would consider giving these patients still concurrent chemoradiation followed by the Durva. Even though
I would have Equipoise doing a trial in the mutants, comparing Durva to some TKI, maybe OC. I don't think we have data on your original trial, Karen, on the percentage of patients who had EGFR mutation. It predated the mutation era.
We do not, and that's unfortunate because it was really getting samples and doing that. We just don't have the samples to do that on, but that's unfortunate.
But yeah, so there was a small representation of EGFR mutation
Very
positive
small.
patients, and it's hard to know what to do with those patients.
Yeah.
But it's a dilemma that
it
we
is.
have to
It is a
grapple with.
dilemma. It was the only group that didn't benefit when you look
I
at
mean,
the forest plot.
My personal preference would just be to give them the chemoradiation therapy.
And not give them
and
the Durva.
not,
Has
and
not
give
given
them
Durva?
I would not in that tiny patient population. That is very, very
I
tiny,
think I'm going to reserve
and I
judgment
think,
until we see the OS curves, and I'm sure it has to be
mean-
broken down for that group.
but it's such a small, it's a very small group. But we have other data to say that patients don't do well with IO therapy. We have consistently shown in the
As-
stage 4 setting that they do not do well.
At least with
Single
IO
agent.
monotherapy.
Therapy.
Yeah.
And that's compared to an active
Yes,
control.
but this is monotherapy
Right.
that we're doing.
Compared to
Post-radiation.
placebo.
Yeah,
So-
but,
so was-
but still EGFR positive.
Let me ask the panel. Corey brought this up. Were you surprised by the rates of pneumonitis being so low?
You know, I'm not surprised by that. Again, we could split hairs a little bit, but pneumonitis is a little bit less in PD-L1 inhibitors than it is in PD-1 inhibitors.
I was surprised. I
But-
thought for sure it would
and
be higher,
so-
and I think the Hoosier group that's looked at just straight consolidation with Pembro, the rates in fact were higher. They were still acceptable, but they weren't the 2 or 3%. They were more on the order of 5 to 8%.
Wasn't this supposed to be a cooperative group study initially, but there was major concerns about the pneumonitis of immunotherapy after radiation that sort of
I don't know.
put it dead in the water?
I'm not sure about that,
I
but,
don't know
but
about
just to
that.
get back to the 2-week subset analysis, the original design of the trial required patients to be randomized within 2
2
weeks.
weeks, that's true.
And then there were accrual issues, and that's why it went
42
to
days.
6 weeks.
Yeah.
But I do think Corey's point about it does kind of leave some decision-making about the timing of radiation. What do you, I'm sorry, of CT scanning and that sort of thing.
And
what
also,
do you do?
would you offer this to a patient that has any degree of pneumonitis? Now,
Right.
granted, radiation changes, you're going to see that on imaging, and that's not that's not clinical or symptomatic pneumonitis.
Right.
But somebody is actually starting to get symptomatic. You're initiating steroids, which we know may counteract. That's not that's the patient I'll probably let things quiet down. I may make a
Right.
decision later, or I may just give them the
Right, right.
consolidative chemo.
But I think, again, we don't know much about this group of patients, you know, what the radiation fields look like. So there's a lot of unanswered questions that I'm sure the answers they
I
have.
would love to see a breakdown
So
for those who had
looking at
PET
that
simulations
and
or
PET
not.
simulation, and so I think they probably have all of that data
hope so.
available. And these are really important questions, particularly as, you know, now what comes next in this field? What comes next? So
Next comes IO combinations, I imagine.
well, I think, you know, the one combination which is now not going forward, it was the IDO Durva combination. So that's not going forward. What other maintenance combinations you could put in there? Anti-CTLA-4 would be,
Potentially.
but
I think the other
and then
option-
moving
Looking at it concurrently.
concurrent,
Yes, that's what I was
and,
saying,
and moving it concurrently. And MD Anderson has completed a trial, and they'll present their data at the World Conference on Lung Cancer, where they've looked at Taxol Carbo plus an IO, and so far
And
again,
radiation.
and radiation concurrently feasible and
Promising.
promising, and hopefully we can move that forward in a cooperative group situation. And I think that would be what many investigators are going to be looking at. So plus the fact that we have now a large body of evidence to say that chemo plus IOs in the stage 4 setting are working well together and tolerated. So I think, and we know that radiation, also a very good immunomodulator. I think some of the questions may become, do we need the Taxol carbo at some point? So what chemotherapy do you really need? That's a down the road question, down the road, or do you need Taxol and carbo?
I think I would want to ask the plus minus RT question first. I think that's the easiest one to do. I think that's an important one. I don't think we're doing well enough in this disease to dial back on the treatment. This is not HPV positive oropharyngeal cancer where we were overtreating patients. I mean, we may argue we're overtreating because we're causing toxicity, but until our outcomes start approaching 70, 80% 5 or 6 year survival, I'm not ready to necessarily cut back on
I think you have to remember that even though we may give a lot of Taxol carboplatin, there are still a lot of people giving cisotopicide, which is toxic. And people are giving PEM-cis and PEM-carbo.
Although cisotopicide often has less pneumonitis after
yeah, but
RT.
it's toxic at the end. It is not easy. And a lot of people still give that. So certainly weekly Taxol carbo. But having said that, again, every patient's individualized, and there are patients that can't tolerate Taxol carboplatin with radiation therapy. I had one just the other day. She was hospitalized twice. So all of these are rare situations, but I think, and that was really a provocative question down the road to say much more work does need to be done.